everybody. Thank you, Eli, for the introduction, the very complete introduction of my person. Okay, this is Florence, by the way. I am here to talk about management of infrabony lesions. And I would start setting the stage with a little bit of history of periodontal regeneration in these defects here. So we are talking 1, 2, 3 wall infrabony components. Everything started, maybe few nows, at the beginning of the last century, 1903. This is the first paper ever published about the use of a barrier to regrow soft tissue and bone tissue around teeth. Japanese paper. There are some Japanese in the class here. Then some science came in, especially from US. It was the period of the 80s and the 60s to 80s, and especially they dealt with bone grafts. Then came the Sture-Niemann period. Sture started what I like to call the modern periodontal regeneration. I was quite lucky to be with Sture in 1982 when he published his first paper on barriers. So I was exposed to modern periodontal regeneration quite early. I don't have the time I'm going on, you know? I don't know the time. Sorry, I don't know the time. I don't have the time I'm going. The timer, please. So I don't know what I am doing. Thank you. So let us have a look to the development of materials in modern age. Of course, taking our step from Japanese paper. And for some years, we have been using materials very close to Japanese paper, starting from Sture-Niemann, lab filters, rubber dam, whatever. Then came some science into it from companies. The FTBA was proposed in the beginning of late 80s. Then non-resorbable barriers came in. Then bioresorbable barriers came in. Then amelogenins entered the stage. Then combination therapy was proposed. And lately, growth factors entered the stage. Not in Europe, but entered the stage. Today we are left with a handful of possible products for regeneration. We have histologic demonstrations, Eli already talked about that, supporting the properties of these materials. And we have science showing the additional benefit of these regenerative materials on top of flap alone. And here are the quantities. The bars are explaining the additional benefit in terms of clinical attachment level gain. The FDBA, barriers, amelogenins, combination therapy, growth factors. And you see, some of these appear to perform better, more powerfully than others. What about the flaps? The flaps have been developing a lot through time. I started personally, 1982, by cutting the flaps like Reinfeldt proposed, modified Whitman flap. Then Henrietta Kay had the brilliant idea that maybe preserving the interdental soft tissue was something to be done in regeneration, and we followed the idea of Takei, proposing the papilla preservation flaps. Then we thought, why don't we do it in a better way by using an operating microscope and a microsurgical mentality? And following that, we came into what we call minimally invasive surgery. I believe today we are left with the papilla preservation flaps and minimally invasive surgery to play with periodontal regeneration. I would like to show to you the differences in performance of these various flap approaches. The flaps without regenerative materials, starting from the modified Widman flap. In intra-body defects, we gain about 1.6 millimeters of clinical attachment on average. Applying a papilla preservation flap, we go up to 2.5. Applying the minimally invasive surgical technique, we go up to 2.8. Applying the modified minimally invasive surgical technique, the one with only the backup flap, we get up to 4.1. So there is a growing performance of the flaps. They are not all equal. Now, if we go to this very nice study proposed by Tu some years ago, what did Tu build up? He was looking to the development over time of the performances of periodontal regeneration, and he compared the different performances over time of, flaps alone and flaps plus barriers. And you see that there is a growing amount of clinical attachment gained through time with both. But the additional benefit of applying a barrier on top of a flap is not increasing, meaning that the increment in clinical attachment level was mainly based upon improvements in the flap design. The same was true with amelogenics. So there is a growing clinical attachment level gain through time, especially due to the performance of the flap. Let us now to take modern time, including in the picture the minimally invasive surgical procedures. And we take as an example studies based on the use of amelogenics. Here is a study in which we have compared the modified papilla preservation technique alone to the same with the addition of EMD. And you see there is a statistically significant difference there. When we did the same with the minimally invasive surgical procedure, the difference between the two therapies became borderline significant. And when we did the same with the modified minimally invasive surgical technique, we didn't see any difference. They did the same. So if we apply these outcomes to the two models, and we add on the modern minimally invasive surgical technique, this development in flap design probably is the future, because the difference in therapy is now decreasing in a way that flap is paralleling the performance of flap plus EMD. Now, this is based, this information is already supported. It's supported by our study showing no differences among modified mist-based procedure with or without regenerative materials. From another study from Leonardo Trombelli, who did the same and had the same outcome. And from an Indian group from Mishra, who used our flap approach with or without growth factors, and you saw no difference between test and control. Now, this is due, in part at least, to the increasing performance of flap surgery. We started with access flap, the modified Widman flap, in which we had failure of surgery in all of our cases, going through the papilla preservation technique, in which we were able to obtain primary closure on top of the regenerative material in about 70% of the cases. This performance was increased greatly by using microsurgery to more than 90 and became better and better with minimally invasive surgical procedure. We are now applying flaps that basically do not fail on top of what we are doing, on top of regenerative material. Not only that, but by applying a minimally invasive surgical procedure, we enhance blood clot stability, and we reduce flap mobility, and we improve space maintenance. By applying these, developing flap designs and evolution in regenerative materials, with our group we have been able to greatly increase over time our ability to grow clinical attachment. We started in the early 90s publishing data with a little less than 4 millimeter clinical attachment level gain, and we lasted in the early times with clinical attachment level gains close to 8 millimeters. Not only that, we had also the chance to play with aesthetics, because by improving flap design we have been able to reduce gingival recession to really fractions of millimeters. And this has a lot to do with prognosis on one side, aesthetics on the other side. Let us try to build up a strategy now with these elements in hand. We have these materials on one side. We have these procedures on the other side. And we have a way to do it. Let us have a look at the different flap design and try to understand what is the potential here, starting from the papilla preservation flaps. This is a video done in 1992 showing a large papilla preservation flap. This flap was designed to host barriers, exposed a lot of bone with horizontal extension and apicocoronal extension, and the papilla was preserved and reversed on the palatal side. What can we do here? Here we can use all of the materials that we have been discussing. We can place grafts, amelogenics, growth factors, barriers, combination, whatever. And get out with an outcomes like this after 21 years. If we think minimally invasive, and we are in front of a very similar defect as we have seen before, if we think minimally invasive, we will not invade the neighboring papilla. We will cut a very short buccal flap, very short. We will play around the papilla and elevate a very short lingual flap. The flap will be just enough to get the access to the defect for debridement, just enough to see the residual bone and play with it. Now, what do we do here? Here we cannot use all those materials. This flap is not designed for barrier placement, for example. This flap is for sure designed to put something in, like amelogenics, like grafts, like growth factors, whatever. It's a completely different story, and out of this we can get out with an outcome like you see now after the 8 years. Let us to make another jump into the modified minimally invasive surgical procedure. Here we have a very similar defect, 10 millimeter deep, and we are cutting a very conservative buccal flap again, cutting through the interdental papilla and invading the buccal side of the two neighboring teeth without invading the other papillae. Rise up, very tiny buccal flap, down to the bone crest, and we work under the papilla without elevating it. The papilla stay in place. Now here what we have? We have a very powerful condition in which a very stable site will host the blood clot to form in. We will have enormous stability here, the papilla keeping the space. and by closing the flap, everything will be well protected. But what we can do here, can we use a barrier here? No. Can we use a combination with barriers and biomaterials? No. We can input something in there. Again, fill in, if we consider that this is what we want to do. Now let us to see how this case came about. Here we have the blood clot that was formed, and we are closing. We are closing with a vertical internal modified mattress suture, like we do all times. We have been proposing this kind of suturing technique for years. And after primary closure, we send the patient down. So what we have seen here is the pure flap. And this is the performance of the pure flap. We have the case after 4 years. And this is the potential of this flap without any periodontal material, regenerative material in. We have seen the performances, the clinical performances of this flap. And what we have seen is that this kind of approach is giving as much clinical attachment level gain as the same with the added regenerative materials. Can we push it harder? I'm following the ELI idea, and you know that I am on that idea since 30 years. Look this case, here we are 2014, and you see a degree 1 furcation involvement and a rather healthy site, a very small intrabony component. The probing depth there is 4 millimeters. Let us have a look 5 years before. This was 5 years before. Yes, the tooth was vital. You all were thinking, is it vital or not? It was vital. We took vitality because we had to scrape the apex of that tooth. And this was the distal root completely hanging in the empty space, and was a through and through furcation here. And after application of our procedure, we got out with this kind of outcome. So, of course, this was a hopeless tooth, and is in the mouth. You know that we published a study about hopeless teeth, treating cases like you see in the screen there. These are all teeth that are considered in the common sense to be extracted. We randomized 50 of those teeth, and in 25 we proposed periodontal regeneration. 25 were extracted and replaced either with tooth-supported reconstruction or implant-supported reconstruction. I showed to you one of those cases in surgery. And of course, here we cannot apply a minimally invasive surgical procedure. Here we have to apply a large papilla preservation flap. And what you see here is a tooth completely detached from periodontal attachment. And we are applying regenerative material here because here we need the help of regenerative materials for sure. And this is the case as it started, and this is the case after 10 years. And I want to really drive your attention also to aesthetics, and really try to understand if with any replacement you could do the same in terms of aesthetics, not only of tooth preservation. What are the outcomes? And here I've shown to you some new data on top of what is already published. At 1 year, we gained a lot of attachment, of course, close to 8 millimeters of clinical attachment level gain because the defects were huge. We started with 25 hopeless teeth. We ended up at 1 year with 23 favorable teeth, with favorable prognosis, meaning in function, with shallow sulci, with attachment and bone back regrown around the roots. Two of those teeth were still hopeless, in my opinion, and I extracted those two teeth. So I extracted 2 out of 25 hopeless teeth. After 5 years, clinical attachment was very stable, and also the tooth prognosis remained the same. 23 favorable teeth out of 25 hopeless at the beginning. What happens now? These are data of the last week. I am completing the 10-year follow-up of these cases. After 10 years, we have still a fantastic stability of clinical attachment, and we have lost an extra tooth, unfortunately for a trauma. Was a central incisor, was weak, but she got a trauma in the incisor and was lost. But now we have, you see, a survival rate of 92% after 5 years and 88% after 10 years. And we are talking about survival of hopeless teeth. So think upon that. And Eli, let us to have a look to what is more convenient, because this is what we have been looking for. Here you have the comparison between the two groups. The group in which we saved teeth with regeneration and the group where we extracted and replaced the teeth. And we are talking about number of dental visits, chair time, and the time to complete therapy for each of the procedures, and also monetary cost. Therapy and follow-up for 5 years, including the maintenance of these teeth. This is the figure for periodontal regeneration, so for the teeth that have been saved. And this is the figure for replaced teeth. And when we look at the differences, almost all of these values are significantly different. And if you look to the monetary cost, is close to be half in saving teeth than replacing with either implants or bridges. When we calculated cost effectiveness, by far regeneration of single teeth was the best. So yes, Eli, I follow you. It is indeed extremely convenient economically and from all the aspects to try and save teeth. What about stability over time? Look again at a case. It's a case, a shot of 1 year ago, 6 months ago. And again you see a rather nice dentogingival unit with nice gingiva and the bone close to be perfect. 20 years before was like this. And we were able to change the prognosis of this tooth in a static area in such a way and maintain the tooth in such a way that after 20 years is still there, aesthetically pleasant and healthy. We now, out of our study published in 2004 on a very large group of cases, that tooth survival of those severely compromised teeth is up to 96% after 10 years. After that study, there have been published others supporting a very important concept. Stability over time, stability of those teeth, is based upon compliance of the patients with a good recall system, very good oral hygiene of those patients, and no smoke. Patients who do smoke, do not clean well, and do not comply with the recall system, lose attachment either in the regenerated site or and in the rest of the mouth. So the matter is not the regenerated site, it's the condition of the mouth. And now I want to show to you preliminary data on the longest controlled clinical trial ever published in periodontal regeneration, and this is coming now in publication next year. And here we want to answer another key question: is it better to apply a flap or regenerate teeth? And here we are talking the papilla preservation flaps, the very large ones that we've been proposing at the beginning. In the management of intrabony lesions, here we started with 3 groups that were treated with a modified papilla preservation technique and titanium reinforced barriers, a second group with another regenerative approach based on barriers, and the third group on flap surgery. We had the 1-year follow-up, and it's published in 1995, and this is a 20-year follow-up. These are the bars showing clinical attachment level gain at 1 year of the 3 groups. And after 20 years, we had 1, 2, and 1 dropouts in the 3 groups. So we're quite lucky to have most of this population still in our practice, following a very stringent recall system. We observe complete stability in the group treated with the modified papilla preservation flap and titanium reinforced barriers, a very limited amount of attachment loss in the second regenerative group, and a consistent and a significant amount of clinical attachment loss in the cases treated with the modified Widman flap. We calculated the recurrences and the need for re-interventions during the years and the survival of these 3 groups. And this is the flap group, and you see we were forced to apply re-intervention on 15 times, considering all the groups, and we lost 2 teeth. We extracted 2 of those teeth during the recall system. Survival going down to 86%. The 2 regenerative groups were burdened by very limited amount of re-interventions during time, and we preserved all the teeth, so we had 100% survival. We have calculated also the average cost of re-intervention during the 20 years of follow-up. And you see you have figures after 6, 14, and 20 years. This is a flap group. And you see the monetary cost, the mean cumulative frequencies in euros. The figure is much smaller in the regenerative group, being the smallest in the modified papilla preservation plus titanium barriers group. And this is the diagram showing to you the differences in cost among the 3 groups. So, my dear friends, it is indeed a good news. It's not a good news. It's something that we know for many, many years. Regeneration is our winning arrow in the management of infrabony lesion. Thank you for your kind attention.